do a rundown, sort of head to toe, day to night, to talk about respiratory care issues in patients with ALS. I mean, one of the things that we know after doing this for, oh my gosh, I've been doing this with you guys for 10 years now, is that we don't take care of nerves and muscles, we take care of people. And so it really is a 360 look. And so we're going to try to start with the day looking at head to toe. So we're going to start by looking at the nose. There are a lot of issues that go on with the nose for patients that have ALS. The biggest one of which is that just the nose is a smaller opening. So as the diaphragm gets weak and it's difficult to breathe, it becomes more difficult to get air in and out of the nose. It becomes difficult to clear the nose of secretions. And so we talk to our patients about using a lot of techniques. Sprays, things like Astelin and Atrovent, which can be very helpful for the average patient, may not be able to work in someone who has ALS and motor neuron disease, because in order to get those medicines up, you have to have a strong sniff. And the ability to really drive that medication to where it needs to go relies on a strong diaphragm, which may not be there. As a result, we frequently recommend the use of pills like non-sedating antihistamines or allergy medicines like Singulair, but because those pills don't require a strong diaphragm, they can oftentimes be more successful. We also use devices like those little breathe right strips like the football players use, really to just increase that volume of air that can go through the nose can be very helpful. We also use things like nebulizers, which allow you to very slowly intake medicine to open up either the nose or the lungs. Humidifiers are super important to avoid dryness, because as you breathe more and more through your mouth, you don't moisturize the way the nose should. And sometimes we recommend the use of something called a little sucker, which is literally for babies. That's its brand name, the little sucker. And it helps to really put in the nose to suction secretions if needed. We also teach our patients how to clear their nose using something called a cough assist, and we'll see that later in the talk. If we talk about the mouth and oral care becomes super important for our patients with ALS, because aspiration of oral contents is the most common cause of pneumonia for our patients, and pneumonia and respiratory impairment is the most common source of both morbidity and mortality in our patient population. What's super interesting and sort of more the new update is that what we've now realized is that data that previously only was apparent in hospitals looking at patients who were receiving tube feeds now relates to our patients at home with ALS who are 100% tube fed. The most important of which, let me see if this is here. Yeah, this up, you guys can't see it up there. See, this is where I need the pointer. So if you can see this graph right here, it's looking at a survey of bacteria that's in the mouth for patients who are being 100% tube fed. And what you can see is that the bacteria, which are most commonly associated with pneumonia, are present much more commonly if you're not eating and chewing your own food, which means we really need to talk about oral care. How do you brush your teeth? The importance of getting antibacterial care to the mouth. And so because of that, we do a lot of discussion of oral hygiene within our clinic. So there are things that we can do to help. The first is making sure our patients get regular dental cleanings, and if your regular dentist can't get you in because they can't get a power chair in or they're not used to taking care of people with disabilities, our job is to help find a dentist that can work with you. In addition, we recommend the use of something called chlorhexidine. Chlorhexidine in the hospital is used as a toothpaste, but it's not available on an outpatient base as a toothpaste. Instead, it is a mouthwash. And so we can get chlorhexidine mouthwash, and then you can use these kinds of either toothbrushes or sponges to apply that to the mouth. And if our patients have significant swallow problems, we don't want them to choke, we can get a suction adapter to go on to the end to assist with that. In addition, we want to make sure that the mouth gets adequate hydration, and that hydration comes from having really good humidifiers in the room. And the other thing is that frequently we talk about the secretions in the back of the mouth being very difficult to get at. You'll see there's a picture there of something called the No Bite 5. That's that green device that's there, which is now starting to be used both in hospices and in ICUs for patients who have a difficult time getting to those back of the throat secretions. This device can be used with a suction to get back there and really clean out that airway. And when we talk about the saliva that's in the back there, it's often very, very thick. And what we end up with is trying to have to make this decision about, is the saliva too thick, in which case we want to moisturize the back of the throat and the mouth to help get it out, or is the saliva too thin and that drooling, watery saliva is hitting the back of the throat and actually causing people to choke. Now, it's important to know that the anatomy, which is up on the picture ahead of us, really dictates how we do this care. And because I don't have a pointer, you're just going to have to look at my hands here. This is what I usually use as my model in the clinic. This is the floor of the mouth, and this is the tongue. And the tongue sort of sits in the floor of the mouth, and its usual job is to move around within the mouth. Saliva comes from the glands at the back of the throat, and usually as the tongue moves around, it moves the saliva to the roof of the mouth and the back of the throat. And unfortunately, in a patient with ALS for whom the tongue is weak and does not move, you can end up with the roof of the mouth and the back of the throat very, very dry, but with a very watery floor of the mouth in which watery drip from saliva is causing choking, etc. It's really tough for our patients because at the same time they feel both too wet and too dry. And that can be very frustrating, both for you as patients to communicate to your physicians and your loved ones, and for us to come up with a good therapy plan. And so what we try to do is targeted medications. So we may use something like a saline nebulizer or a spray, like I'm going to show you on the next slide, to really hit specifically the roof of the mouth. And at the same time, we may try to dry secretions with medications. So here you can see for that thick saliva, we may use artificial saliva, especially the spray. We may use a facial top steamer or ask you to steam in, say, a steam shower. Or you could use saline nebulizers. That's those little pink tubes up there. In addition, our nurses will tell you that there are other home remedies that we've had a lot of success with, like fresh papaya juice or Concord grape juice. The natural enzymes and acids can really help to break down that thick saliva. In the UK, they're very fond of lemon drops, not taken off as much here, but it's very popular there. And then if you talk to our nurse advocate team, they will tell you avoid dairy. I will tell you as a physician, we can't find any good data on that. What I will tell you is this: if you avoid the dairy and the secretions get better, why go back to it? We have options. And so we do recommend that elimination diets can be healthy for our patients. The only thing you can't eliminate is enough fluid. We don't want people getting dehydrated. We have other therapies that are coming down the pike which are a little bit more aggressive. Surgery, in which the salivary glands can be cut. Radiotherapy, where we use very low-dose radiation to ablate the glands. Scopolamine patches to dry and to help to reduce the amount of saliva produced to begin with. Ipratropium, that's usually used for the lungs or for the nose, we can apply in the mouth. We use medications. The most common of which for us to use is that amitriptyline or Elavil. We like to give it for people who have trouble at night because it also helps them to sleep. And we've used a lot of botulinum toxin, which is injected straight into the parotid glands in order to reduce the production of saliva. We've also had it injected into the submandibular glands to give a secondary boost to the effect of that Botox. We actually can use two brands, either Botox or Myoblock, and we usually do this as a staged procedure so that people don't get too dry too quickly. Well, and once the bottle's open, the bottle's got to be used, so, maybe the pulmonologist gets a little help out of it. As we move down, we go from the mouth to the vocal cords. The vocal cords are just a muscle, just like any other muscle in your body. And just like you can get Charlie horses or contractions of the muscles in someone who has ALS, remember that that can happen in a patient at their vocal cords. Sometimes this presents as a cough or as a wheeze, but the most important part to know is that these events are different than coughing and wheezing because they happen when you inhale. If the specific complaint is that the cough or the wheeze is preventing you from getting a breath in rather than being a problem with getting a breath out, then it's a sign to us that the vocal cords have probably actually closed and spasmed, and that we need to get a muscle relaxant there to open them up. The most common muscle relaxant that we use is lorazepam solution, which can be used as a rescue medication, just put as a couple of drops under the tongue to relax those muscles on an as-needed basis. If we find that that kind of emergency relief is needed a couple of times a week, then we recommend the use of a prophylactic long-acting medication like baclofen. As we move down from the throat to the chest wall, it's important to know that the chest wall can develop stiffness. That stiffness comes because we get spasticity of the chest wall muscles themselves, but we also get, because of the weakness of the muscle, a failure to completely expand. Now that's going to be true of every joint in the body, right? Because all of our muscles can be affected. So just like we know with the shoulder, it's important to do range of motion muscles all the way like this, because if we don't do full range of motion muscle, you can get, say, this is your shoulder here, and this is the bone going into the joint. We know that if we don't do a full range of motion, that you can get scar tissue forming within that capsule. That scar tissue limits our ability to use that muscle. It also causes a tremendous amount of pain, and really pain medicine can't get over it. If there was ever a time in which an ounce of prevention was a pound of cure, it's with range of motion exercises